Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Doug. How are you doing today?
Other than pesky spring cold, I'm doing great. Thanks, Dennis.
Perfect. So, you introduced yourself a couple weeks ago, working in the cardiothoracic ICU. So I thought you would be the perfect guy to ask this question about vasopressors, how to use them appropriately.
Great. Bread and butter.
It's bread and butter for you. So, you look in the sepsis CPGs, you look in essentially any other distributive shock things, right? But especially sepsis, they talk about using norepinephrine. They talk about vasopressin, dobutamine, and kind of epi is like kind of the back shelf type of stuff. Why do they stick me with epi and all the good stuff goes to you guys?
Well, it's not so much that we stick you with epi. It's sort of more of a beware the man with one gun analogy. That in soft medicine, as in many things soft, that items that have multiple uses are probably going to take precedence over items that do not, right? And so in the case of vasopressors or catecholamines, epinephrine has multiple uses. You can use it in cardiac arrest. You can use it as a vasopressor. You can use it in anaphylaxis, where it is first line. It's not, off the reservation. And so the thought was, the rationale behind having epinephrine be the vasopressor of choice for far forward medicine is that, if you could get comfortable or as comfortable as possible learning one of these very complicated drugs with very serious side effects, better than having 3 or 4 that you never get familiar with.
Yep. No, I think it's a wise choice. I think it's very versatile. And we still don't learn it really well.
No, and it in prepping for the podcast, there are actually arguments to be made against epinephrine because the nomenclature has now become so confusing, which I'm happy to get into if you want. And if somebody who works in an ICU full time is confused by all the different naming conventions and concentrations and naming of the concentrations, then I think it is confusing. I think, an 18 delta could make an argument for taking norepinephrine, which comes in one concentration and, is a great pressor, has fewer of the arrhythmic side effects and doesn't, break down the lactic acid, and EpiPens for anaphylaxis. I mean, I think, and if you want to get to alternative strategies for loadout at sometime in the podcast, we can discuss that.
Yeah. Oh, perfect. So speaking of those horrible side effects that happen, like I hit somebody with epinephrine, what kind of things should I expect?
The biggest risk of giving epinephrine is really if the high concentration dose, the milligram per milliliter dose, formerly known as the 1 to 1,000 dose or the code dose, epi. If a milligram of that is given IV, you can really jack somebody's heart rate, put them into an unstable arrhythmia, jack their blood pressure, into like the 200s over 100s, and potentially cause some hypertension-related side effects like stroke or intracerebral hemorrhage. So for that reason alone, number one, I think it's probably not a great idea to carry that concentration, and because the only use for it really is in cardiac arrest, which we're probably not going to be dealing with, and it's a more concentrated intermuscular dose for anaphylaxis, but you can still get there with the 0.1 milligram per milliliter, the more dilute dose. And so basically pushing undiluted epinephrine IV is your biggest risk. Your other associated adverse effects, it is because it has more beta-1 effects than norepinephrine. You can get some arrhythmias. It is used actually to increase heart rate in patients who are bradycardic. It's not first line. Dopamine is first line for that, but it certainly can help, and it's more arrhythmogenic than norepinephrine or vasopressin. And then I guess what are the other? Oh, and the other big side effect is that epinephrine breaks down and metabolizes into one of its metabolites is lactic acid. So if you use epinephrine in an infusion, probably more than push doses, for a long enough period of time at high enough doses, you'll get a lactic acidosis that you'll then have to deal with or ignore, depending on what the pH does.
When would something like that be a real problem?
Well, when would the lactic acidosis be a problem? If you're running it as an infusion, we see it in our heart patients who come out and they're on some norepinephrine, they're on some epinephrine. They probably some of them have a lactic acidosis anyway, just because of the stress of surgery, and maybe they're all hypovolemic. But then, as you go on and resuscitate them and the lactic acid's still climbing, you kind of have to attribute that to the epinephrine. So, so that's not a great side effect of it.
Yeah, but the risk is coming from the pH.
The risk comes from the pH, right? If you have a lactic acid of 6 and a pH of 7.4, you have a clinically less significant lactic acid level than if you had a lactic acid of 6 and a pH of 7.1. The challenge in our environment is we don't really have a way of measuring pH. You're going to have to kind of back your way into figuring out that your patient's acidotic, as we talked about in, I think, another podcast.
Right. If you don't measure it, it doesn't matter.
What's that?
If you don't measure it, it doesn't matter.
That's true. If you don't check it, everything's going to be all right. Yeah. But, if they're bleeding, if you're going up and up on your pressors and they're not responding, those are all kind of signs that maybe you have a clinically significant acidosis. But again, it's a not so desirable side effect of epinephrine given as a pressor.
So again, like the sepsis CPGs, more specifically, my first thing is giving fluids. A lot of the research papers out there are saying we need to move pressors early. That's okay. We need to move pressors early and not give so much fluid. So the temptation, I think, on my side is to jump directly into pressors. What do you think about fluids? Should we be bothering with it? I would like to not have to carry it.
No, we should definitely be bothering with fluid, especially for sepsis. Excuse me. Because that is, the gold standard for sepsis, resuscitation. And we deviate from that only because we have to, not because we can. So carry your fluids, get your fluids in. The so what of jumping to pressors without giving fluids is that giving pressors in an unresuscitated patient is probably going to cause more harm than good, right? So you get septic, it's a distributive shock, your blood vessels dilate, now you've got, 5 liters of fluid in a 10-liter vessel as opposed to 5 liters of fluid in a 5-liter vessel. And so the pressure, there's going to be a lot of empty space in there, right? And if you don't fill that space back up with some intravascular volume and you start squeezing down, you may not get enough preload in the heart, and the heart may overwork and not function well or not function at all. So you got to have something in the ventricles for the heart to squeeze out. And if you don't replace the fluid that's been lost in hypovolemic shock, or the fluid that's been third spaced and is hiding out in the blood vessels under lower pressure in distributive shock and inflammatory response, then your pressors aren't going to do any good.
Okay. No, it makes 100% sense. So the sepsis CPG, and I'm guessing the same could be true for anaphylactic patient who's becoming hypotensive as well.
Yeah, and in fact, I'd read a little bit more about anaphylaxis for the podcast because that's just not something that we see very often. Most anaphylactic shock in the hospital is dealt with in the emergency department. It's very rare that it happens on the floor. It does. Sometimes we have a drug reaction, and I've definitely had cases of it. But just to refamiliarize myself with it, and it is really the mother of all distributive shocks. It's like, all of a sudden somebody just turns a dial and your blood vessels go like that, and your fluid volume, your intravascular volume pressure goes like that, and the treatment for that, first and foremost, actually is fluids. Because number one, that's what you've got on hand, probably. It's what you can get on board the quickest. Number two is you really do have some intravascular volume that's been lost through third spacing that you need to replace. So volume resuscitation has an equally, if not more important role in anaphylaxis as it does in sepsis. And in fact, the guidelines for anaphylaxis for starting an epi infusion say only in patients that have low blood pressure that is resistant to repeated doses of EpiPen or push dose intermuscular epi and volume resuscitation. Only in that case do you think about starting an epi drip.
Okay. It does. So fluid-wise, the sepsis CPG says 30 cc's per kilogram within 3 hours. Now, does that mean I hang a giant vet bag of lactated ringers and drip that in over 3 hours?
No, just like with burn resuscitation, it's really it's not a target that you have to hit. It's a guideline for how much fluid the patient might need, right? And if their blood pressure normalizes or gets good enough, stable and adequate enough pressure, and by that I mean a mean arterial pressure of like 60 to 65 millimeters of mercury and stable, and they have signs that their organ perfusion is improving, their skin is not mottled, their urine output is something, 20, 30 cc's an hour, their mentation improves if they're not sedated and intubated already, then, you can back off.
Okay. So would I be safe to do like 500 to a liter bolus, see how they respond? And if I win, then I stop. If I don't, then maybe another 500 and use that 30 cc's as like a cutoff?
Not so much a cutoff. It's more, like I said, I actually believe that the surviving sepsis guidelines sort of do encourage you to give that much, but I think that, most practitioners would see that as a suggestion of how much the patient might need, not a slam all this in every patient in the first 3 hours in every sepsis case. So, we certainly see the complications of burn resuscitation, and sepsis resuscitation is no different, really. It's usually less volume, but excuse me. I'm always a little wary of guidelines that say, put in this target volume of fluid in all patients every time.
Yeah. Yeah. I mean, I don't know, maybe I'm slow to the game or what, but I think whenever anybody is writing guidelines or a CPG or whatever, they have a specific patient in mind when they're writing it. And sometimes your patient doesn't match.
Yeah, if your patient is 100 kilos and my patient is, 38 kilos, I guess it is, cc's per kilo, but my patient's going to need less fluid, which that guideline does address. So, I'd say it's out there as a recommendation for, hey, these patients can need a lot of fluid. Start giving it, give it quickly, get their antibiotics on board quickly, and assess their response. And if they stabilize, you can back off. And if they don't, you may need to go, the whole way and then keep going. Patients, there's some fascinating case reports out of the Ebola epidemic in Africa, back in the 2010s, early 2010s, because it happened right after I got to my posting down here in North Carolina, and they were getting 20 liters of fluid over the course of their hospitalization, plus, just because their volume losses were so immense and their third spacing was so immense.
So I'm given some fluids. I'm not really winning, but I haven't also reached my end state with amount of fluids that have been at least written down in the guidelines. When do you say fluids aren't working, start squeezing them?
Two cases. One is if you can deduce from the history or from a bedside ultrasound that your patient has heart failure, then you're probably not going to hit them with a whole 30 cc's per kilogram before you start a pressor. Excuse me. You might hit them with 500 and another 500. If they come up, great. But if they're not, that's when you might want to move to a pressor.
I am. So we just asked you about, when to press. We're talking about, you mentioned heart failure. I'm giving them fluids. I'm not really getting much of a response out of it.
I think the other place that you'd move to a pressor early is, you're aggressively resuscitating them. You have your first liter in, you start that, open it wide open, and the patient is just profoundly sick. Like their MAP is like in the 40s or 50s, like low 50s. And you put that, first liter of fluid in and it doesn't budge. You may want to, give them a push dose of epi or start a drip, just to give them some sort of a perfusion pressure as you're resuscitating them. And then, who knows? They may respond to volume, and they just needed some time, and you can back off on the pressor, or they may be that sick that it's going to take a combination. Usually it's door number 2. Usually if they're sick enough to not respond to volume, to bring their blood pressure up, they're going to need a pressor, and they're going to need it for a while, a couple of days at least. Does that make sense?
Okay. It does. It does. Now, I carry multiple EpiPens. I also carry a plethora of 1 cc, 1 milligram per ml epinephrine. I can squeeze them and get as high a blood pressure as I want. However, I do know that you don't necessarily want to do that. How far, like, what are my end goals? You know, it's like I read the guidelines with epi use. It says 5 micrograms per minute all the way out to 20 micrograms per minute. That's a 4-fold increase.
Right. It's interesting because the guidelines are a lot broader than what I've seen epi used in clinical use. 5 micrograms in a 100 kilogram person is like 0.05 micrograms per kilo per minute. And that's, sort of on the moderate end of the starting dose for us. We'd probably start at 0.02. We get to 0.05 a lot on people, but we tend to not run it more than 0.5, which would be, let me see, what would 0.5 be? 5 micrograms a minute? And you said 5 to 20
micrograms per minute.
Yeah, so 20 would be 0.2. Yeah, that's about reasonable. Yeah, because 20 micrograms per minute and a 100 kilo guy would be 0.2. No, it would be 2. It'd be 0.2 micrograms per kilo per minute. Yeah, that's fine. We generally run up to 0.3. So actually, that's fine.
Okay. So good. I have room on the far end.
You've got room on the far end, and I just did math in public, which is a fraught exercise.
You set yourself up for that one.
Well, and it's fraught and super risky with something like epinephrine. So if you do the math wrong, right? So, but no, that's if you're just going to go micrograms per minute, that's not that bad. Where you get into trouble, though, is if you're doing that dosing range in somebody who's lighter. So a 50 kilogram person, double those doses, right? That's 0.1 to, what did I say, 0.2, 0.4. You're still probably okay.
So I think what I found, at least with my narcotic use, start low, I can always go higher.
Correct. Always start low.
What am I looking for?
Basically, you're looking for a response of blood pressure, right? Okay. Epi is very rapid onset, within seconds. It's very short duration, which is why push dose epi is great for getting somebody stable while you're mixing a drip, but you wouldn't really want to do it. It's not like push dose ketamine where, you're good for 20, 30 minutes. Push dose epi is like you might be good for 10 if you're lucky. Yeah. So you're going to see you're going to see a response to epi within seconds.
Yes. Yep. So good blood pressure.
Yeah, MAP of 60, 65 millimeters of mercury. And again, all the other markers of resuscitation, hopefully some urine output.
Good cap refill.
Cap refill, modeling as well.
Okay. Skin tone comes back.
Skin color comes back.
Hopefully LOC starts coming back.
Yes, exactly. And even if they're sedated and on event, you can still get a neuro exam. You can turn your sedation down. You can ask them to squeeze your hand. We get neuro exams on sedated, ventilated patients all the time.
Like we said, with pressors, you can keep going. You can squeeze them down, and now it starts to become dangerous. How do I know when I'm starting to get into that dangerous zone? Because a map of 65 is good.
What's that?
I said a map of 65 is good, but 100 would be better.
No, a map of 65 is actually all you need. And in some cases, if it's really, in general, if you're having a hard time, if somebody's really hypotensive, you may have a hard time getting into a goal map. And in which case, sick and stable is okay, right? So a map of 65 is fine, and it doesn't take much of a systolic blood pressure to get you there. The diastolic affects it more, right? Because it's 2 times diastolic plus systolic. And diastolic is more affected by, your end diastolic volume, which is your intravascular volume, and that's where the resuscitation comes in, right?
Now, does an epi, would you have a more profound effect on the diastolic side because you're squeezing it?
You'd have both, right? Because it's got beta 1 effects, which is going to increase your cardiac contractility. So every squeeze of the heart, you're going to get more cardiac output, which is going to drive up your systolic. But you're also got alpha 1, which is squeezing the blood vessels, which is going to help both actually, but diastolic for sure.
Okay, so you're getting that wide pulse pressure from your distributed shock. You should be seeing that thing closing in
with a pressor, yeah.
With a pressor, yeah. Any other? So like, endpoints are good. Hey, all the things that told me this guy's in shock start winding back. How do I know if I'm starting to get into a dangerous zone? Is it like sometimes I'm seeing heart rates climbing into the 120s, 130s, 140s?
Yeah, obviously, if you put somebody on an epi drip more than push, probably, but sometimes both. If you give someone epinephrine and their heart rate jumps, that's a concerning side effect, especially if it doesn't come right back down again. If their heart rate is stable and remember, sick patients are tachycardic too, right? Mm-hmm. Patients with sepsis rarely have a heart rate under 100, at least so it's more the change, right? If their heart rate's 110 because they're sick and you give them epi and their heart rate stays 110, it's the disease process, is not the epi, or 120 and it stays 120. It's more like if it's 110 and it goes to 130. That's when, and we do have to change our selection of pressors and inotropes in the ICU for tachycardia complications.
Could that be just a sign that they need some more volume?
No, it could be, but it's probably a sign that they're just more sensitive to the drug. And there's no rhyme or reason for who's going to get epi and have a faster heart rate and who's not.
So what would you say is like an endpoint that if their heart rate gets above 150?
I'd say if it changes 20 beats a minute or more, then that's probably a time to at least back off. If you're at a whatever 10 mics per minute rate, back down to 5 if you can. Maybe you have to turn the drug off and walk it back up again.
Okay, so maybe go back to your push doses.
Maybe you have to have regrets and go back to your supply sergeant and get norepinephrine the next time you deploy.
Right. See, went back to they're holding out on us. What does norepinephrine do for me? Like, why is it the first line, at least for sepsis?
Norepinephrine is, and it's interesting because, we're talking out of one side of our mouth that epinephrine is the drug you should carry, and then the other side of our mouth is saying, but norepinephrine has really got all these things going for it that make it a safer drug in many ways, or maybe not safer, but a drug that's easier to manage in many ways. It's definitely doesn't have the arrhythmia complications that Epi has. It's more of it has more alpha effect, right, which is vasoconstricting, and less beta effect. Now, it does have some beta effect. There is some increase in cardiac contractility that comes with norepinephrine, but not to the extent that epinephrine has, and very, very little effect on heart rate and bad arrhythmias. So that's the benefit. I generally tell the students and the residents that if they only learn one pressor, learn norepinephrine.
So let's say we trade spots. I take your job as a cardiothoracic ICU, which it will be complete chaos, but that's not your problem because you're stuck out in the woods. Would you be okay controlling either sepsis, really bad anaphylaxis? All you got's epi.
Yeah.
Okay.
Yeah.
Perfect.
Yeah, because it's kind of like the best fluid to use is the one you have. The best pressor to use is the one you have. I think all the catecholamine vasopressors, at least the big two, epi and norepi, each have their advantages, each have their disadvantages. Yeah.
Perfect.
I might want a Glock, but if somebody handed me a Colt, I'd probably know how to shoot. I'd probably learn how to shoot it and defend myself.
Yeah. All you got to do is pull the trigger.
There's some aiming involved. People.
The noise usually scares them.
No, and maybe the takeaway for all of this is, you're not wrong if you pull epi and you learn to use epi because it's got this wide range of effects of uses. Right? It's a great drug for cardiogenic shock, which probably is not really big in our community. Hopefully not. It's a great drug it's the drug for anaphylaxis. There's no question about it. Anaphylaxis is treated with fluids and epinephrine. That's what you need. And if you don't have it, your patient might not make it. And it's a decent drug for all hypovolemic and vasodilatory shocks. You just have to know the side effects. The other strategy would be, you pull norepinephrine and you carry that for shock, vasodilatory shock, or all shock, except for anaphylaxis, and then you carry EpiPens, or you carry both, and you learn them both. Okay. Or you make cheat sheets for both in your med box.
If there was any advice you would want to give to somebody who is alone and afraid, just with their EpiPens, what advice would you give?
Alone and afraid with an anaphylactic patient and their EpiPens, or somebody else in their EpiPens?
Anaphylactic, but he's refractory to that first dose because it was delayed.
I would start getting some fluids on board. And that's a patient who might take 2-3 liters of fluids. And then, give him a second dose and see how he does. And then
He gets better.
He gets better. There you go. Then just be vigilant to see, if he's going to need a third dose, if he's going to rebound or break through, if the dose will, if the effects of whatever the anaphylactic stimulus are are over before the epi wears off, or if they continue and he needs more.
All right, perfect. Thank you, Doug. I really appreciate you walking me through all this.
You're welcome. Not very straightforward. This is like more on the complex side of critical care medicine, and certainly austere critical care medicine.
Yeah, absolutely. Unfortunately, none of my patients titrate their complexity to my skill. They just kind of show up.
They just kind of show up. I love it. Well, thanks for asking me on. I hope it was more clear than mud.
Nope, I think it was.
Good. Appreciate it.
All right. Have a good night.
Yep. You too, Dennis.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.